We're going to start with the drugs that will alter sympathetic activity, since ANS is so relevant to every chapter that we see so far. And in doing so, let's review the alpha-2 agonists. And these alpha-2 agonists really are represented on your exam by the two primary ones, the drugs clonidine and methyl-dopa, sometimes known as alpha-methyl-dopa. When I'm looking at these two drugs as alpha-2 agonists, they work on that presynaptic receptor that is GI coupled, and as that is going to cause a negative feedback on synthesis and release of norepi. That's what we called earlier on a decreased sympathetic outflow. Well, that decreased sympathetic outflow means less norepinephrine is released in the synapse. Less norepinephrine means indirectly those drugs are decreasing alpha-1 and decreasing beta-1 stimulation. From the decrease in alpha-1, what would you expect? I'm sure you're saying decreased TPR is what a decreased alpha-1 activity is going to result in. Surely from the decreased beta-1 activity, I will see a decreased heart rate. So you see this statement? You have a drug that vasodilates, yet it causes bradycardia. This is pretty neat. That means a strong effect on blood pressure. You know, you could use these drugs for even moderate hypertension. So blood pressure where the systolic might be in excess of 160 in this patient. So we're not talking, you know, just the initial treatment of hypertension. It is also pretty neat to notice that with a vasodilator, I do not see reflex tachycardia. That simply stems from the fact that there is no norepinephrine to be released when I'm an alpha-2 agonist. Now, promise I will explain to you in our CNS section after the cardiovascular why clonidine is used in opiate withdrawal. For right now, just put it in one little cell in your brain and then wait until later. One story that will definitely show up on a number of board exam questions on any step is the use of methyl-dopa in the hypertensive management in pregnancy. Now, if you recall in general principles, one big reason to choose a drug for pregnant women is the fact that it would have high plasma protein binding. But then in turn, high protein binding for drugs that can always behave as hapten, they're foreign molecules in your body, can mean immune dyscrasia. So look at this slide. The first thing you see of board and clinical relevance for that drug methyl-dopa we use in pregnancy, a positive Coombs test. And positive Coombs test, you know they use for autoimmune hemolytic anemias, for destructions of RBCs that would be associated with an immune basis. You see, there's always a reason for everything. Think of methyl-dopa, a drug with high plasma protein binding, therefore little free fraction to bother the fetus or the embryo that the mother is carrying, but unfortunately, the pitfall with it is going to be to cause some potential immune dyscrasia. That high protein binding tends to keep the hypersensitivity in the blood, hence the positive Coombs test. There is a risk of associated hemolysis with a drug like methyl-dopa. We don't see this with clonidine. CNS depression. Well, when a drug that interferes with norepinephrine can cross a blood-brain barrier, I know that that drug will have a depressant effect. I know that because drugs to treat depression increase norepinephrine and or serotonin to have their effect. Now, this is not really an ANS effect. It's a central effect of neurotransmitters such as norepinephrine, such as acetylcholine in the previous chapters, which is simply they are stimulants in our brain. Blocking any of their activity either through receptor antagonism or simply through decreased synthesis and release, such as with methyl-dopa and clonidine, will result in CNS depression. Both drugs would not improve the depressive mood of a patient. Otherwise, why do you think these drugs will cause edema? You thinking renin, angiotensin, aldosterone? I'm going to call it RAA. I'm sure you are. Huh? You know that when you lower blood pressure, that kidney of ours will sense this and decide to put out renin. That means I'm going to have to add diuretics with alpha-2 agonist. Hey, drug companies already thought of this for us, and they have combined in the same pill thiazides and alpha-2 agonists for decades, so that like this we don't have to add yet a separate medication to our walking pharmacies that our patients become when they have cardiovascular ailments. Alpha-2 agonist, because of the issue of CNS depression, the issue of alpha-2 agonism decreasing norepi, are very classically board tested in the drug interaction with TCAs. Look, a TCA blocks reuptake in order to increase norepinephrine levels in the brain. Of course, the alpha-2 agonist is trying to be antihypertensive by lowering that same norepinephrine. You see there is an exact pharmacodynamic opposition between the two medications. If I can say the TCA decreases the antihypertensive effect of clonidine or methyl dopa, you know I'd be just as well able to say that clonidine and methyl dopa decrease the antidepressant effect of a TCA. Expect to see this drug interaction again in the CNS section. We're talking about depression. Here are two old drugs that none of you probably will still use in practice, yet you find them on step 1 because of the basic concepts attached to them. These are old drugs that were working on storage vesicles. Well, if you don't like the word storage vesicles, you know we mean the synaptic vesicles of the nerve terminal, the ones that contain neurotransmitters. Reserpine is a drug that destroys such vesicles. And in destroying these vesicles, it does it not only to the neurotransmitter norepi, it does it also to dopamine and to serotonin. So as the neurotransmitters are no longer packaged into vesicles, it means when you depolarize the nerve terminal, there's going to be nothing to release. Plus monoamine oxidases will have digested these unpackaged neurotransmitters, so there'll be a severe decrease in all these transmitters in the brain of the patient. Well, that results in severe depression. Actually, so severe that most patients who have had issues with reserpine are not there to talk about it because they committed suicide. Now, this happened back in the 1950s. And back in the 1950s, by observing the effect of reserpine, and at the same time by observing the effect of an anti-TB medication, tuberculosis medication, isoniazid, which was also known as a monoamine oxidase inhibitor by pharmacologists, they noticed that whereas people on reserpine committed suicide and felt very bad, people on isoniazid felt very good. And then came the entire hypothesis that depression are due to basically drops in central norepi, dopamine, and serotonin. And this is the 21st century, and we are still using the same hypothesis developed 50 years ago to make all of our new antidepressants. This is why reserpine is on your exam, because of that severe depression. So the fact that we wrote edema underneath it, that's just to annoy you. That's just to make you repeat to us, this is due to the renin, angiotensin, aldosterone, because I decrease perfusion pressure of a glomerulus. So now, why on earth did we put increased GI secretions? If you block sympathetic, as you will by decreasing norepi in the periphery, who becomes predominant? Parasympathetic. And increased parasympathetic has always meant increased secretions, such as GI secretions. So what would you tell me about a patient with peptic ulcer disease? Would it be good to use these drugs? Obviously not. It would certainly worsen the ulcer disease. Well, you know, at least it would lower their blood pressure. Guanethidine is the other old drug that you're unlikely to use in real life, but you might still find on a step 1 question. Here's the beauty of this one. In order to do its job, which is again to bind to vesicles and not destroy them, but really to decrease norepinephrine release, it uses the reuptake pump. You know, imagine a little diagram like this. This is a nerve terminal, and this is a vesicle releasing norepinephrine. Well, then it works on alpha-1, beta-1 receptors, and whatever receptors are available to that norepi. Norepi is then reuptaken by a little pump that is presynaptic. This is that very same pump that is going to be used by the drug guanethidine. I'm going to call it Gua here, and it re-enters in here and then interferes with norepinephrine release. So to reach its site of action, it needs the reuptake pump. What do TCAs do to that? A tricyclic antidepressant is a drug that can potentially block reuptake. That's where TCAs live. And if this is where TCAs work, then by blocking reuptake, they'll prevent guanethidine from reaching its site of action on the vesicles of norepinephrine. Well, with this, that's what made it to the exam for years, the fact that guanethidine cannot be given with TCAs. This is kind of old information, but if step 1 wants it, give it to them. As far as diarrhea, that's the increased parasympathetic. Edema, yeah, it's still the increased renin, angiotensin, aldosterone. Well, let's leave our drugs that were working presynaptically, interfering with norepinephrine release, and work postsynaptically with alpha-1 or beta-1 receptors. When you look at alpha-1 blockers, the first thing you remind yourself of, since we're not reminding you in this section, are the non-selective alpha blockers, such as the drug of choice in pheochromocytoma. Are you thinking phenoxybenzamine and phentolamine? Or if you want, in case, you can always put them back in the margin of your book. It never hurts to repeat them. There's so many names of drugs to remember. And phenoxybenzamine, phentolamine were reviewed in our autonomic nervous system section, whereas phenoxybenzamine was non-competitive, phentolamine was competitive blocker. Well, we didn't like blocking an alpha-2. So here we want to be the famous selective alpha-1 blockers. And the selective alpha-1 blockers, they're the drugs that end up in osin or zosin, like terazosin, doxazosin, samsulosine. So really when I see one of them, prazosin, I think I would be able to recognize all the others. Don't overweight your memory with them, just know prazosin, you should be fine. As I'm looking at alpha-1 blockers, then the idea is I block the primary receptor for vasoconstriction. As such, I decrease resistance. And I'm decreasing the resistance of both arterioles and veins. The decreased arteriolar resistance will lower the blood pressure significantly, resulting in reflex tachycardia. See this? These are the only sympathetic altering drugs that will cause the classic reflex tachycardia. That is because as you lower the blood pressure, you can still release norepinephrine. And not only you can increase norepinephrine release, you can still also bind to the beta-1 receptors of the heart to cause the tachycardia. So out of all these drugs in that first section, only alpha-1 blockers are associated with reflex tachycardias. Okay, so once you have gone through this, then maybe you would start thinking, how about decreasing venous resistance? Well, that's true really of also an alpha-2 agonist, albeit indirectly through decreased norepinephrine release, or of guanethidine and reserpine, although they do it through vesicle, interfering with norepi release also. If you decrease venous resistance, you decrease preload. And when you decrease preload, it means when you stand up, you're going to start feeling very dizzy and potentially pass out. Basically, that's the orthostatic hypotension we were mentioning in our big page that we started the chapter with. We use alpha-1 blockers for hypertension, fine. We also use them for benign prostatic hypertrophy. And BPH really has nothing to do with alpha receptors. The main idea is that the primary symptoms of BPH in the older male are those of urinary tract obstruction. As the median zone of the prostate gets hyperplastic, there is compression of the urethra to a slit-like opening, and as such there's a problem for that male to empty his bladder. It will mean that male will need to go to the bathroom more often. That frequency of urination will also occur at nighttime, waking up this individual so that they will have frequent nocturia, then suffer insomnia. Imagine then you give them an alpha blocker. Alpha blockers will release the tone of urinary sphincters, particularly those of the trigone. As such, when that patient contracts the detrusor muscles and empties the bladder, there will be a better emptying of this bladder. With a better emptying, there should be less need to go to the bathroom. Really, an alpha blocker is a symptomatic treatment for BPH. All it does is decrease the symptoms associated with BPH. If you really wanted to work on the pathogenesis of BPH, let's not forget that this is an endocrine injury associated with dihydrotestosterone. So blocking the formation of this active form of the male hormone testosterone is really the way to go to work at decreasing the size of that prostate. Where we'll see later drugs such as finasteride and other steroid being 5-alpha reductase inhibitors, These are going to be really the drugs to play with when you want to work on the pathogenesis. However, an antiandrogenic side effect is never liked by male patients, as you know. Primary side effect of the alpha blocker. Well, first dose syncope. Now, what is meant by this is literally the orthostatic hypotension effect. When a patient has never been exposed to an alpha blocker, it's possible that they might pass out by taking the drug. Otherwise, by relaxing the sphincters, it might be good for someone with urinary tract obstruction, but certainly between the increased parasympathetic and the lack of sphincter tone, there's always a potential for urinary incontinence with those drugs. The only point of the advantage of having a good effect on lipid profile is to contrast them to our next story, the beta blockers. Beta blockers, mechanism CANS. Fine. Which mechanism would you choose? That of decreasing the heart rate? Decreasing the contractility of the muscle? You know what? Actually, neither. The main effect of beta blockade, if you remember in the ANS, is to then leave alpha-1 predominance on juxtaglomerular cells of the kidney. That means here, the beta blockers literally work by decreasing renin release. So as antihypertensive, they really work upstream, if you want, of our ACE inhibitors, angiotensin receptor blockers. By suppressing renin production, it will mean they have a truly antihypertensive effect. Now, having said this, of course, bradycardia and decreased cardiac output help too, but never underestimate the decreased renin that will also work on the TPR through angiotensin 2. That is why, when I'm looking at a beta blocker, it becomes a side effect to cause cardiovascular depression when I treat hypertension. That is the potential for AV block in particular. We know beta blockers, when they cross the blood-brain barrier, will have a CNS depressant effect. At the very least, patients will feel tired, fatigued, a little bit slow. They don't feel like doing too much stuff. And surely as you decrease the arousing effect of catecholamines such as norepinephrine, there's always a potential for sexual dysfunction, primarily those of decreased libido. Relevance of such side effects, they're uncomfortable, they're unpleasant, and being so, they can interfere with compliance to the treatment. Otherwise, let's not forget that beta blockers will decrease lipolysis, and as such will tend to increase the levels of lipid in the blood of a patient. If you're normal for your lipids, I doubt seriously a beta blocker would ever result in a clinically overt hyperlipidemia. But if on the other hand you're someone with high cholesterol, it will certainly not help you to be on beta blockers. For that matter, always think that alpha blockers would have been a better choice when it comes to lipid profile alone. However, beta blockers have such advantages when it comes to ischemic heart disease and their consequences that really that increase in lipids more often than not will be totally erased by the use of drugs to lower that patient's lipids. Now, there are always 3 cautions associated with beta blockers use. The problems with asthmatics, vasospastic disease such as Prince-Meadow, such as Raymon, and surely my diabetics. Not only you will mask the hypoglycemic events by blocking the beta-1 receptors, you would for instance decrease the tachycardias, but also keep in mind you would worsen the risk of fasting hypoglycemia by preventing glycogenolysis and gluconeogenesis from working.